This is Dr. Sargisian, and today we'll talk about disorders of hemostasis and as a part of our weekly lecture. Before talking about disorders itself, we need to define what hemostasis is. Hemostasis is a protective mechanism, or the consequence of the protective mechanism of achieving balance or protecting the loss of blood, protecting body from the loss of blood. So hemostasis is occurring by stopping somehow blood flow, and normally blood clots. And blood is usually, we know, it's a fluid and it's a viscous fluid. We shouldn't forget that. However, it will flow freely under normal circumstances when it's inside the vessels. But when the damage to vessels occurs, it will seal the broken blood vessels by a clot. So that's the normal mechanism, very briefly. And abnormally, this may be results of inappropriate clotting or insufficient clotting. So by abnormally, I mean exaggerated efforts to achieve hemostasis or insufficient effort. So when we have inappropriate clotting, as we know from the past, inappropriate from pathophysiology means excessive. So we have hypercoagulative states, and insufficient means we can't clot, and we know that the name for it will be hypocoagulative states. So if it's too much, it's hypercoagulative or inappropriate clotting. If it's too little, it's insufficient or hypocoagulative. Stages of hemostasis are the following. What happens to achieve the hemostasis, we will see that transient vessel vasospasm occurs, and this allows, just very briefly, to stop or slow down the blood flow outside, and then formation of the platelet plug will follow, and then it will be forming a clot, and then formation of the clot will be. So platelets are one of the key players in achieving hemostasis, and platelets are thrombocytes. Like any other cells we know in the blood, erythrocytes, leukocytes, and platelets are thrombocytes. Platelet formation is supported or encouraged or facilitated by thrombopoietin, which is made in liver, kidney, muscle, and bone marrow. So, and by muscle, of course, smooth muscle. So when we have not sufficient amount of platelets, thrombopoietin is made, and which signals bone marrow to produce megakaryocytes, and megakaryocytes are precursors of the platelets. Megakaryocytes are huge formations that eventually break down to numerous platelets. Platelets aren't as long-lived as red blood cells, and platelets live only 8 to 9 days in circulations. And when you're thinking about it, what we are in the state of crisis and we need more platelets, and production will take some time, the good news is that there are lots of platelets stored in the spleen, and when there is a need, the platelets will be released. mediators of hemostasis are chemicals produced by platelets. What happens when injury occurs? They initiate clotting by reacting with proteins that float in the blood, and also another important function is that they help platelets to clump or stick together. Clumping is usually a good process, beneficial process, because it facilitates formation of the clot and facilitate hemostasis at the end. On the other hand, the mediators of hemostasis will also stimulate wound healing and also prevent clumping. Also facilitate the clumping of the platelets to vessel walls. Also, they result in vasoconstriction. They support vasoconstrictions of these vessels. So there are numerous coagulation factors. Liver has an important role besides of helping with digestions and being part of GI system. It has important role of producing these plasma proteins and synthesizing them and basically supplying the blood with the coagulation factors. So this can be described as synthetic function of the liver. Again, it's a synthetic function of the liver to produce clotting factors or otherwise plasma protein. There is one factor which is called von Willebrand factor, and it's made by endothelium, and von Willebrand disease is deficiency of that factor. So you can ask a question: if we have so many coagulation factor, why doesn't all clot? All blood, clot? And the answer is that the plasma proteins or coagulation factors are actually circulating as inactive procoagulation. So this is a description of coagulation cascade with intrinsic and extrinsic flow. You see like how certain factors like factor 12 turns into factor 12A, which stimulates factor 11, which turns into 11A, and eventually this may result in formation of fibrin from fibrinogen. And again, these are the steps, or you see it's like a cascade, like waterfall, or cascade is a waterfall with steps, as you know. So every step the factors drop down and initiating the next. Cyclooxygenase enzymes are the products of metabolism of arachidonic acid, and actually they result in the production of mediator of hemostasis. So the good example of this is the Celebrex, which is non-steroidal anti-inflammatory drug that blocks the production of COX-2, or it's a COX-2 inhibitor, which may reduce the inflammation secondary to arthritis, and as that occurs, the pain secondary to arthritis decreases. However, when people take Celebrex, the COX-1 and thromboxane levels, which is a mediator of hemostasis or a chemical mediator of clotting, occurs or increases, I would say, as compensation, and because of that they may develop the hypercoagulative disorders. And by hypercoagulative disorders, I mean increased risk for stroke, heart attack, or thrombus of any other kind. So what happened that thromboxane A2 increase of it results in the developing of the clot. So that's why the prescription of Celebrex is somewhat limited, or was very limited a few years ago, but now it's again picking up, although there are strict regulations to inform patients about possible side effects and increased risk for stroke and heart attack. However, of course, as anti-inflammatory drug, it works great. But again, if you prescribe it, or if your patient already receives it, they need to know, your patients need to know that there is an increased risk for stroke and heart attack. And that's of course a consequence of increase of one of the clotting mediators, clotting factors, thromboxane A2, as a result of COX-1 metabolism, which comes from arachidonic acid metabolism. Let's look at this scenario. You are taking care of a patient who had a stroke, and physician prescribed tissue plasminogen activator. And at this point, one of the patient's relatives is asking why they didn't give him heparin or warfarin instead. Of course, you know the answer, and you will be explaining this to patient and to patient's family, educating them about this. This situation, it's not hypothetical or uncommon. I can reassure you, sooner or later in your nursing practice this will happen. And there are lots of people that learn from sources like internet, or other internet sources like Wikipedia or somewhere, or have a relative who takes these drugs, and they know that heparin and warfarin used for coagulative disorders, but so they would start inquiring why this, are you trying to harm my relatives? You will see this question in any way, shape and form. That's why it's important to study pathophysiology and know your answers, not because of this only, but it will be helpful for you in the situations like this, when you actually trying to educate the patient and the family. So before we talk about this scenario, let's talk about plasminogen. What is plasminogen? Plasminogen is a plasma protein which is a proenzyme. As we remember, most everything in the blood that circulates in relation to clotting or coagulation is inactive. When plasminogen is converted to active form, it's called plasmin. So plasminogen activators can be formed all over the body in endothelial lining of the vessels, liver and kidneys. And by all over the body, I meant only these three sources, not literally all over the body. So plasmin will be formed from plasminogen, and plasmin is the active substance. So plasmin will help to digest the fibrin, and fibrin also will affect clotting factors such as fibrinogen, factor 5, factor 8, and most importantly prothrombin and factor 12. What's important about this entire process, that the plasminogen will be inactivated by a plasmin inhibitor, or plasmin will be inactivated, which is helpful because the acting of plasmin is only localized to certain clot that we need to dissolve. It's not floating around. But before even plasminogen has a tendency, before even plasminogen is converted to plasmin, we need to activate it. And that's where tissue plasminogen activators come into play. These are naturally synthesized substances, and they can come from different sources. Again, liver, vascular, endothelial lining. So the activators will be released in response to events such as an occlusion of the vein and exercise and other factors such as certain drugs, certain vasoactive drugs, but these factors are very unstable. However, they, at the time they released and they find plasmin until, they find plasminogen and tell plasmin to convert to plasmin. I just said tell plasmin to convert to plasmin, tell plasminogen to convert to plasmin, which starts eating the fibrin and dissolving the clot. So this is how it works. Again, tissue plasminogen activator can be natural or can be synthesized and given as a medication for a stroke, and by stroke we mean the occlusive stroke, thrombotic stroke. So the question, what doctor is trying to accomplish? From here we know doctor is trying to dissolve the clot. So what's the difference between heparin, warfarin, and tissue plasminogen activator? The difference is very simple. The difference is that heparin and warfarin are acting on prevention of blood clot formation, while tissue plasminogen activator, by activating plasminogen, which is converted to plasmin, which is it's the fibrin in the blood clot, are digesting the clot or is digesting the clot. So TPA helps clot digestion, while heparin and warfarin are merely preventing it. Heparin molecules are basically cofactors that work on antithrombin. Antithrombin is a substance that can inactivate thrombin and other clotting factors such as factor 10 and some other factors. So that's how heparin works, and heparin can be synthesized by body itself, while warfarin, we already said that it affects the synthesis of the vitamin K, which is coagulation factor is that's synthesized by the liver. So when we talk about heparin, you need to remember that this is drug that can be digested and cross the GI tract and has to be given by injection, IV, or subcutaneously, and that's how it works. But again, the answer to this scenario is heparin and warfarin are preventing clot formation, while TPA will actively facilitate clot dissolution. Hypercoagulation disorders can be result of several factors. When increased of the number of the platelets. You have too many platelets in the blood. Platelet aggregation, which means platelets are clumping too much together. Endothelial damage, and as I talked about, this endothelial damage can result in the decrease of production of several anti-clotting factors such as heparin or even tissue plasminogen activator, and increased procoagulation factors for some reason, and decreased anticoagulation factor. And by decreased anticoagulation factors, we can, von Willebrand factor is part of this type of decrease, but also von Willebrand is a consequence of endothelial damage. What can influence decreased platelets levels or thrombocytopenia? Penia is decreased number and cyto cells, so thrombocytopenia, decreased number of the platelets. Decreased production, increased destruction, and you just have too many clots forming at the same time, so we just can't provide enough platelets. Even our production is normal. Also, you can have normal platelet production number, but they are having impaired platelet function. They're not functioning normally. I'd like to talk to disseminated intravascular coagulation as a disorder who is rather paradoxical because it involves hypercoagulability and hypocoagulability. So at the same time, too much clotting will occur, and at the same time, too little clotting will occur. So what happens? Some type of trigger will initiate one of the pathways in coagulation, and it may be either intrinsic or extrinsic, doesn't matter. So intrinsic pathway can be activated with extensive endothelial lining damage, and endothelial lining damage can occur through injury from infection, virus, some type of immune disorder, blood stasis. Extrinsic at the same time may occur when tissue factors become activated. And extrinsic pathway is very common in OB/GYN disorders, obstetrics complications, basically. That's the extrinsic factor. So also complications of cancer may lead to this, and also big trauma. But intrinsic pathway, it's really endothelial injury. Again, this goes with what I said before. Intrinsic pathway is endothelial injury. Extrinsic is tissue injury, of course. So both of them, doesn't matter what's the pathway, they result in thrombin generation. And thrombin generation in this case is quite extensive. And extensive production of thrombin results in clotting, thrombosis, and thrombosis can bring two things into play. When we have thrombosis with lots of vascular fibrin deposited, so we'll have ischemia in the tissues. Also, the blood cells itself will be destructed. too much thrombin leads to plasminogen getting into the play. So plasminogen or TPAs will jump on plasminogen and activate it, which result in plasmin generation, which will result in blood clot destruction or fibrinolysis, and the products of destruction of the blood clot or fibrin, they will inhibit thrombin and platelet aggregation. So basically we have so much clot destruction because we had too much clot to deal with to start with, so we don't want any more forming, because the fibrin products, that's what they're thinking, that's what they're doing, and they prevent thrombin and platelet aggregation. So this all will result in bleeding. Thrombin production also will result in platelets consumption for the clot, of course, so we don't have enough platelets to provide clots. So all this again will result in bleeding. So we have two results in here, and it's paradoxical. We have thrombosis, clotting, and we have too much bleeding at the same time. So how to deal with this? Even this is a coagulation disorder, even it seems paradoxical, and we're all thinking let's just deal with coagulation, although the coagulation mechanisms per se not effective. They work as they're supposed to work. So to treat this, it's important to treat the underlying disorders. So if disseminated intravascular coagulation occurs, then person may exhibit different signs and symptoms secondary to failure of the vital organs such as kidney, heart, lung, even brain, that clots may deposit, or extensive bleeding may occur. At the same time, as I said, hemolytic anemia can happen, and patient may have signs of hypoxia. So primary disease management is very important in here. Also, if patient present with excessive bleeding, important to replenish those plasma proteins and somehow correct that deficiency. At the same time, we may consider giving anticoagulants such as heparin. Again, this is very complex and critical condition, and to summarize, it's hyper and hypocoagulation occur at the same time, and the diagram describes it very well. Treatment involves A, treatment of primary disorder, and B, replenishment of lost clotting factors, and also administration of anti-clotting substances such as heparin. So, and again, the main thing about this is paradoxical. Bleeding and clotting occur pretty much at the same time.